Okay, so today we start with the third type of study design, cohort studies. Okay, these are the learning objective. Most importantly is to identify and understand, not only understand, but be able to identify all the aspect of cohort study, all the aspect of the design of cohort study, specifically understand and identify its types, the different strategies in order to assemble a cohort, how to improve participation, and when we think about cohort, meaning that we establish the cohort, we assess the exposure. So what are key issues in measuring exposure in terms of method of assessment, and what are the challenges? What are the key considerations when we decide what outcome we want to assess at the end of the follow-up, and discuss attrition and how it affects validity of a cohort study, as well as strategies for retention. So a cohort study is par excellence a study that looks at analyzing an exposure and how it's related to an outcome. So it's an analytical type of study. The question is, it is meant to answer questions such as, does running improve your mental well-being? Is exposure to smoking in pregnancy associated with an increased risk of intrapartum complications? So this kind of a question that looks at improve, increase, risk, decline are best addressed longitudinally. So it means that we want to follow up people to determine the outcome starting from the exposure. Of course, always the best design to address the analytic question is an RCT, is a randomized controlled trial. Doesn't have to be clinical, but a randomized trial, such as this one. So if we want to look how much physical activity affect a certain outcome, we randomize a group of participants, rigorous training program of running, and then in addition to an awareness session, and then another group we give only awareness session. We randomly allocate them to this group, and then we look at the outcome in the control arm, which is only, for instance, awareness session, and the outcome in the treatment or in the intervention arm, which is a training program of running in addition to an awareness session. So this is for, So this is an example with RCT, effect of running therapy on depression, design of a randomized controlled trial in adult patients. However, this kind of question, does running improve cardiovascular disease? Does running improve your depression? So on and so forth, are not always easily answered by an RCT. It's not always easy to randomly allocate people into this kind of exposure. Why? Sometimes the exposure is okay. If we're looking at the protective measure, yes, you give some people the intervention, which is improving their well-being by exercise. But if you're looking at something that is harmful, you cannot allocate people to a harmful exposure. So ethically, sometimes you cannot do an experimental design. Sometimes if you're looking at particular risk factors that are non-modifiable, of course, an RCT is not the answer. Whenever you think about an RCT design, you think of an outcome that occurred during a short period of time, within a short period of time. And sometimes you have to wait longer to see the outcome. So it is more costly and time consuming to be in an experimental design with large number. First, of course, even recruiting for RCT is not as easy. People volunteer in RCT, compliant with the treatment or with the program that we establish, and sometimes the contamination. And RCT, this is the next study design that will be given by Dr. Khalil Asmar in March 10. So the alternative to answer this kind of question, does running improve mental well-being, or is smoking increase the risk of harmful complication among pregnant women can be an alternative, would be observational cohort studies. So it's like emulating an RCT, and looking at the natural experiment. So looking at what's happening and then try to see what are the outcome. So again, because randomization is not possible, because we're not able to randomize, the best, as we said, is to randomize into those exposure group, exposed, not exposed. So therefore, in cohort study, selection of the people, of the participant, is of utmost importance. It's very important because we are not randomizing, we are not blind in terms of what each person is taking or is exposed to. So therefore, it's very important to control the blinding, to control confounder, because without randomization, it means that we have a lot of confounding effect that we need to account for. And there might be other sources of systematic error. People go to the field training. So there are so many things that we have to take care of. But most importantly, is the issue of the confounding effect that need to be accounted for a lot. And while selecting the subject, we need to be very careful not to have a selection bias when we select our subject. So this is the observational study on the effect of running. This is running on, if I'm not mistaken, the long-term effect of nationwide. So this is, I think this is a big study called the Netherlands Start to Run. So they have recruited people to be part of a training multi-center prospective study. So people have, it's a Start to Run program. And then, of course, some people were running, some people were not running. So they had like a digital running log for people. And then they follow up after 6, 12, 24, and 52 weeks. And they look at specifically outcome. So RR is defined. So any muscular ailment, and I'm not sure what was exactly the outcome. But I mean, this is something that's not an RCT, so they did not allocate people into a program, but what they did is they recruited the novice runner, meaning runner who haven't run before, and not athletes, and then they try to change their lifestyle, but each one has a, sorry, this is Farhan Safa, please, wait. Sorry. Okay, so this is a typical cohort. We have a recruitment period, and these are the people who are recruited. Some people are exposed, some of them are not exposed. We follow up. During the follow-up, some people are lost to follow-up, exposed or non-exposed, and then we check how many out of those who were followed exposed have developed the outcome, and out of those who were not exposed, how many developed the outcome. So we identify the cohort, and the cohort are people with common and specific characteristic, and then start with identifying who has the characteristic that we are assessing in terms of the exposure, and they should have. Most importantly is that we start with people who don't have the outcome. Sometimes we select a cohort, and the cohort, when we assess, they have the outcome. So these people have to be either removed, I mean, we select them out, so we don't take them, or we take note that they have the disease, so therefore they are not part of the cohort, but they are not at risk of developing the outcome. So we have to make sure that whenever we are measuring the outcome in a cohort study, we are measuring it among people who are at risk, so they haven't developed yet the outcome. And this is actually the main concept of the cohort study. When is it warranted? So case control study is warranted when we have rare disease, when usually the cases and the controls are found in healthcare settings, when we want to look at one outcome but several exposure. So here the cohort is when we don't start with the cohort. Usually we have some evidence of an association either from a case control or from cross-section study. So there should be some evidence of this association before we moved into a very resource intensive and a lot of commitment for the cohort. But of course, when we want to look at the risk of the disease rather than the burden of the disease, we need a cohort. When we want to see changes, so if people have fluctuation in their HbA1c, how does it affect their kidney diseases or eye diseases or whatever? And when the exposure is rare, also we tend to identify a cohort with the exposure, and then we compare them with the non-exposure, which is the common. And then, of course, when we have resources, this is very important to have resources. To do a cohort, you need really large numbers, especially if you want to look at a long-term cohort. And this requires resources in terms of human resources, training, follow-up, because a cohort, meaning that you start with so you have at least two waves of data collection. So this is how you have to think about it. And why is it too expensive? Because you have wave one, and it becomes a cohort when you go back to these people and you have a wave two, and maybe wave three and wave four. And this means you are in the field collecting data, which is very much resource intensive. So the cohort could be a sample of a very defined area. Of course, the most important one that we know about, and one of the first big cohort, is the Framingham cohort. So Framingham is a city. Rotterdam, elderly cohort. Tilda is this is Ireland, also longitudinal cohort for older adults. So it's a defined geographic area, and people have the same characteristic in terms of the place of residence. Occupational cohort also are types of cohort. So we take a cohort of people who have worked in factories that has where exposure to asbestos is there, people who work in textile. Another occupational cohort are radiologists, so people who are exposed to UV light, whatever, not UV light, radiation. Sometimes my cohort is a very specific group of a certain characteristic, like taking HIV patient, so recruiting a cohort of HIV and follow up to see when do they convert into AIDS, for instance. Or I take HIV, I see who's taking medication, who has some, and how are their lifestyle affecting the progression of the disease. So this is an HIV cohort. Or people with sleep apnea. Sometimes, and which is one of the most common forms of cohort, are a general cohort, but they are built around specific profession, not to look at how the profession is linked to the outcome, but because of the convenience, because of the availability of these participants, such as nurses or bridge doctors, we have a large study on health professional, all types of health professional that I think it was in the US. So the nurses study is not a study about nurses. It's because the cohort allows me to collect data. Nurses are available and I have records on them. Cohort could be short or long. So I could have a cohort of a pregnant woman. I recruit them when they are in the prenatal clinic. I collect data on them, and then I look at the effect of some of the exposure on their babies. And then the follow-up can be only 9 months. I can have a follow-up of women after they deliver, to look at postpartum depression. Postpartum is up to 12 weeks after delivery. So therefore, this is again short duration compared to others where you have longer duration. Usually, when we have cohort of kids or cohort of young men or adult or something, so follow-up usually is like over 20 years. It's true that data are collected regularly, like every two years or 4 years, but still it is built to see effect over a long period of time. It could be large, it could be small. Ours, the Lebanon Saha study is 3,000, but we can have a cohort of 100 or 300. And it could be, we could be looking at a cohort where we only have exposure at the beginning and the outcome, and a cohort where we wanted to see that change in exposure. But it could be very much one time, like if you look at the cohort of the port blast, so you take a cohort of those who were exposed to the blast. So this is one-time exposure, and then you see after 2 or 3 years what's happening to this cohort. Cohort as well could be, by the way, descriptive, i.e. no a priori hypothesis. So I found this example. It's an old example. I couldn't actually find a different one. I haven't searched much. So this is older children and adolescents living with perinatally acquired human immune deficiency infections. So they wanted to look at what are the clinic immunologic and psychosocial characteristic of children living with perinatal acquired HIV, whatever. So it's a descriptive cohort, only looking at those who surviving perinatally infected children, what are their the progress or the symptoms that they have over beyond age 9 years. Okay, so most importantly are the types of the cohort study, so that we which is prospective versus retrospective, and I know that you have been exposed to this, and that's why I'm not going fast. Or closed versus open cohort, and you can always stop me if you want, interrupt me if you want. Prospective versus retrospective, I think there's always a confusion with respect to retrospective. I think prospective is clearer. It's a concurrent, it's concurrent or longitudinal. So we start with the exposure. So if we are now here, this is now. Okay, so we assess exposure, and we march with the cohort. Okay, we march with the cohort to check the outcome. So we are in 2026, and I want to see the effect of this war on the mental well-being after like 1 or 2 years. So I collect now data on the people who were displaced, who had injuries, who had any family member or relative who were affected in terms of physical injury, if they themselves had any physical injuries, if they have lost their home, if they have lost their business, and then we look at the outcome after a certain time. In contrast, the retrospective study, I can identify people, for instance, who were, for instance, we're talking about something that's honestly, it's not. I'm not using it. I'm just giving a real example. So if I want to see the effect of the Israeli aggression, and specifically thinking about the massive destruction, I can take people who were living in the southern suburb in 2006, right? So 2006. So I go back, and I can follow and see now what they feel like, what's happening to them. So the exposure, it's a retrospective, it's historical. So historically, they were in the southern suburb in 2006. Let's say I have some records. Where these records are, okay, you can tell me. I'm not going to go to them and say, were you exposed to the war in 2006? I can have list of all the buildings that were destroyed, for instance, with the name of the tenants. So who were there? So at least I know that I have a listing, and those people, I can trace them to see what they're feeling, what are they doing right now. So exposure happened in 2006, but I identify the cohort from 2006. I don't call them now and to say, were you exposed in 2006? So this is my exposure that happened in a cohort that I was able to identify 20 years ago. Otherwise, I can take now the people who are affected and follow them up for 20 years. So even I go back to a cohort that existed in 2006. I know that they were there. I know that their houses were destroyed, and see what happened to them right now. And it could be like ambidirectional. So you see, you start with the 2006, you see what's happening to them now, and then you can follow up on them again. Okay. So the prospective, as I said, it's characterized by so we collect the data now on now we collect the data on exposure. So I'm talking about the present. Okay, so I see who was displaced, who left, and I follow them up, and then I move through time as they age. Okay. So this is a typical one, prospective, 1948, and then they define the population, they look who's exposed, who's not exposed, and then they follow up to look at, and every 2 years they had a follow-up to look at what's their hospitalization, if they have developed hypertension. And they have, their main outcome was coronary heart disease. This is another prospective study. This is what the one I told you about. This is the health professions follow-up that began in 1986. So the purpose was to evaluate a series of hypotheses about men's health relating nutritional factor to the incidence of serious illness as cancer, heart disease, so on and so forth. And this is the main page if you are interested. So it's more dietary as in relation to cancer, heart disease, and other vascular diseases. So this is an only male study, and that was done to complement actually the nurses study that was all female. So the retrospective, again, it uses historical data to determine exposure. So I have to think about a group of people who were exposed in the past to a certain event. And I think illustrating it with the war is the best example, because now if I want to look at atrocity, how it relates to mental health, I can recruit now people who are displaced and then follow up, or go back and then check if I have data from the Ministry of Social Affairs, from any source, about the exposure of people 20 years back, and then I see what's happening to them right now. I don't ask them about their exposure, because I recruit them based on their exposure. So I call them a historical cohort, and then I look at what are the subsequent disease status in the present. So of course, it has the advantage of the follow-up, so therefore it's prospective. The exposure is measured. The most important thing about cohort is that the exposure is measured independent of the outcome, so people are not contaminated or affected by their disease to recall the exposure as in the case control study. The retrospective, if you find a retrospective cohort that could answer your research question, is definitely less expensive. You don't have the commitment for follow-up of a long time, because already 20 years have passed. But the issue is that to find cases, to find your historical cohort, to identify that historical cohort. And this is usually done specifically when prevalence of exposure is extremely low. So let's say most of the occupational cohort are retrospective cohorts. So if I want to see the effect of a detergent, for instance, on workers who work in detergent factories, so those who produce detergent, so if they have, if it affects their cancer, whatever. So I don't, so since the exposure is rare, so it will be very difficult to find those people who are exposed. I go back to some of the factory that manufacture those detergent, I don't know what we call them, produce, manufacture, whatever. And then we check on them, we see the employment record to see how many of them at this point in time have been diagnosed with cancer, leukemia, or other type of cancer. Retrospective cohort is really good. As I said, low cost, minimum resources, much less commitment from the researcher, but it depends on several things. One is that when you identify your retrospective cohort, you have to have enough information on the exposure at baseline. So you have to, it's not like, yes, let's say you identified all the factories that manufacture detergent. So you have to go back to the record. Do they carry data on who's actually close to the production place where detergent are manufactured? Do we have the length of exposure, meaning that how long have they been employed in that factory? Do we have data on their health in general while they were in the factory? Do we have data on the confounder? Because we might have good data on the exposure, but I don't have good data on some of the confounders that needs to be adjusted for. This is an observational type of cohort. This is very important. And then people must have enough high exposure. So I will have to take, if we're talking about occupational cohort, it means that they have to have spent enough time in that factory to be exposed, and therefore to show the excess risk of the disease after 20 years in the factory. Sometimes and the issue is how to find those people, how to trace. This is another issue. So those people who were identified as a cohort, as let's say the Zook power plant, right? So people do suffer, the environment of the Zook plant do suffer. So what about their employees? So can I trace their employees? Do I have any mechanism or any system or registry that would allow me to trace those people where they are? Because you need to identify them on registry or individually tracing them. So if they died, do we have a good system where I can say, for instance, Thanos Shaheen, who worked for 20 years in Zook power plant, can I find his vital status after 20 years? So this is very important. Is it easy? How many Thanos Shaheen? How can I link Thanos Shaheen and the death certificate and vital registration system or any other type of registry? Again, as I said, so this is one. And then, so people even, again, going back to the factory, to the issue of the factory. Some people, let's say, are frontliner. So they are in the first line of production, but then maybe after 2-3 years, they have more supervisory role. So it means that their exposure to detergent or to any other risk factor changes. Does this information exist? So do we have record on change in exposure? So do I have, can I know that this person have worked 3 years with intense exposure and then the remaining years less exposure? How can I take this into consideration? And is this information available? As I said, do we have information on confounder or other diseases? And then when I take this kind of example, it means I need a comparison group. So this comparison group at the time when this historical cohort 20 years back, who would be their comparison group? Maybe another factory with no exposure to detergent, maybe employees within the factory who are administrative, who don't have any exposure, direct exposure to detergent. So can you think about a retrospective cohort other than occupational, other than those people who were exposed to war? For instance, the cohort of those in the area where the Beirut blast happened. This is an excellent cohort when you look at severe trauma and what's happening now. So you can go get all the information about the people who lost their family member, who lost their houses, who were living in that area, and you can see what's happening to them right now. Can you think of other retrospective cohort? So a historical cohort that will allow you to address a certain hypothesis. For instance, something about hypertension in young age and how it's related to cognitive decline when people after 60 years of age. Any thoughts? How can you build a cohort using AUB data, admin data? Ladies, I don't know
You
yes,
can
Rana.
look at the charts, review the medical charts, let's say for a certain now the charts of people, let's say employees, and then we
But
can
who's your
decide on the
history?
exposure.
But who's your cohort? Who would be your cohort? You're thinking about the outcome. I'm thinking who
Yeah,
would be your cohort at AUB? If you want to think about AUB as a place where you would assemble a cohort, what would be a retrospective cohort, a possible retrospective cohort?
maybe the students, if they have the right at university students, and then we
Okay, so you can take,
add
okay, so
that then.
if you're looking at a hypothesis where we're looking at a certain exposure at early at the, not late adolescent or for young people between 18 to 24, and you want to see an exposure after when they are mid-adulthood, for instance. So you can recruit, so you can see who joined AUB. So you don't want to start now and then follow them up. So you go back, maybe how long do you want the follow-up to be, like 10 years? Okay, so you go back to 2016, look at all the cohort of students who joined AUB. They should be between 18 to 24, right? Almost, because 18 are the undergrad and 20s are the grad. And then try to trace these people, what happened to them. So this is for a cohort of students. So it's a cohort of students who joined in 2016. That's your cohort. The cohort of students should have data on their medical record, right? When they joined AUB, they do medical exam, right? So if your exposure is available when they joined, such as their if they have I don't know what kind of I forgot actually. For me, it's been a long time. So what kind of data, medical data they collect, or even while they are at AUB, they should have some data, right? So we consider that their time at AUB, this is where the exposure happened, and you collect as much data from the medical record, and then you assess them in 2026. So you have to trace them in 2026. A better retrospective cohort at AUB would be professors. So you want to look at, for instance, hypertension or blood pressure, and specifically, and other cardiovascular risk factor, and dementia, right? So what I can do, or dementia or cognitive decline, is identify a cohort of professors, okay, whose age was between 30 to 45 when they joined AUB. And when they joined AUB, they should have also gone through medical exam to get their HIP, so on and so forth. And of course, they should have some kind of a medical record from the university health services. So I would look at them when they were recruited maybe 20 years ago. So I develop, or I establish a cohort of professors. So my cohort are professors who joined AUB in 1999, 2000, right? 1999, 2000. Of course, I have specific inclusion-exclusion criteria. Sorry, I'm Hanan عندي صف. Bye. Sorry, I can't mute my telephone. Okay, let me see if it works now. So the cohort is the cohort of the professor who joined in 2000, and then I look at their record right now. So now I can go to them and administer a battery of cognitive battery, and look at their cognitive well-being. I can have a longer also follow up, identify professor who joined AUB even before, like maybe 1980 or 1990. If they are in their 30, now they should be in their 80s or 90. And then I would look at, I should have enough data from the record of AUB admin that allows me to identify the exposure, such as their blood pressure when they joined, maybe some data that could have been collected. So that's a retrospective cohort. So again, this is a retrospective cohort of leukemia and other cancer and benzene worker. We are here. So there was a research team. The research team was in 1981 to 1983. So they identified those who were worker in factories in 1972. 1972. So the factory who have worked at least for 6 months in factories with benzene worker, and the controls were factories with no benzene exposure. And then the follow-up, which did not was done from 1972 to 1980, was not by the researcher, but this is the historical cohort that started in 1972. And then they look in 1981, what happened to these people. The outcome was current continued employment, retirement, transfer, as well as other vital status. These are some of the example of retrospective, and I will move on. Okay, so these are example. Another type of cohort is fixed versus closed, open versus closed cohort. This is very important because it also direct the way you're going to analyze the data, how you deal with the data. So either you are with fixed members, so these are the people who will be with you throughout, and you don't add anyone. So there is a cohort, a very famous cohort is called Cohort of Cambridge cohort of people older than 75. So they recruited in Cambridge all people who are 75 and over, and then they followed them up. And the 2 years ago, there were no more, no one in the cohort, everyone died. But this is really a fixed cohort, so I did not add up. And usually people are very stable. They remain in the same place, and usually it becomes smaller in time, right? Because you don't replenish the cohort. A particular one is atomic bomb survivor, the one on atomic bomb survivor, and CCC 75, Cambridge cohort for older adult, which are 75 and older. An open or dynamic cohort. So open and dynamic new member may join at any point. You can replenish. So we start with 3,000. We expect then in wave 2 that we have a smaller number of people who are now 60. So we started with people who are 60 years in 2024. After 5 years or 6 years, we will have less. We won't have anyone between 60 and 65. So we replenish the cohort. So we add the new members to keep at least to have a good number of people in the age group 65 to, so we wanted a dynamic one. So we replenished the cohort. It still could be geographically restricted, and it could be small or short period of time. It depends. Usually open cohort, there's no rule that it should be small or long, small or short. But the issue is that when you have a dynamic, and if you have a large one, it will be too difficult to handle, and it becomes a little bit complicated to analyze. So how do we start a cohort? So now we're going into the design. So the most important thing is what? Assemble the cohort. So get the cohort, establish the cohort. The cohort, which is at the baseline, is like a cross-section study. So I want to get people in, all right? So we want large cohort study. We want them. Because this is all about seeing outcomes and looking at risk, and you want to have power. So you want to have large scale cohort, and they are needed and very valuable to establish. Large scale cohort are needed, but valuable to, I think there's an issue of the but is something wrong. They are valuable to establish. So this valuable, but they are costly to establish, costly to collect data, and costly for the follow-up. Just as some information, first, at the baseline, we don't have always a high response rate. So when you go to collect your cohort, I mean, to establish your cohort, you don't have always a high response rate. So people at the beginning, they don't participate. So in Framingham study, the response rate at baseline was 69. But we know that recently there have been really lower response rate. However, I can tell you that for our study in Al Sahha, we have a very high response rate. The final one is in the 70s or a high upper 60, 70. But in some places or in some subgroup, we have really a very high response rate in terms of approaching them to participate. So, and if we don't have good participation at baseline, what happens? So if you go and if you want 3,000 and you knock on doors and you have a lot of refusal, what would happen?
You would lose power in your study, no?
Power
Like
you can
have a smaller sample.
okay. Power you can add. I mean, you can inflate your sample size to keep your at least whatever power you need. But if you knock on the door and people keep refusing, and then you knock on another one, and then so what would happen?
This cause a bias.
It causes selection bias. So you might end
Selection
up with a population, with your cohort that does not look like the population of the population from where you have selected your cohort. But then it depends on whether you are taking a cohort that represents your population. For us, when we recruited Al Sahha, the cohort of older adult, we wanted the older adult to represent the older adults in Beirut, to represent the older adult in the Qada of Zahle, which is the area, the district in central Bekaa. So we wanted to represent. However, when we knocked on the door, we ended up with really a larger number or larger proportion of females than expected. So it means that in the selection, we have oversampled female, and it did not represent really the proportion of male to female. So we have some kind of an issue in selecting. So then we started addressing this by choosing different times of the day to get more males in the study. And people who refuse, also we had refusal, of course, could be very much different than people who accept to participate in the study. So therefore, very important is when we assemble the cohort is to have good strategies for recruitment, data collection, and follow-up. So we need to think about those strategies. And these should be part of a proposal when you write it. So how can you maximize participation? What would be the best method to retain people, to collect data, so on and so forth. So what type of first cohort we think about? So it could be general population cohort, like the one we've done, all population in one area, or a representative sample. Framingham and Rotterdam are all population in an area. Framingham is 18 to 64. The Rotterdam were people who were 60 and above. It could be a sample or all population in a very limited geographic area. Or as we said, like earlier, the nurses' health study, the health profession for males. We have also workers, Taiwan workers, male worker or something. So a special group of population by occupation or by professional group, or people who have specific type of exposure, if the exposure is rare, like physical, chemical, or biological. So the recruitment then, how you select them depends on the type of cohort. So whether you want to have everyone let's say Beirut. So do you want to take everyone in Beirut who has particular characteristic, or a sample? So therefore, how would you recruit if it's a sample? How would you recruit if you want to have everyone there? What available infrastructure do you have? Do you have sampling frame? Do you have registries? Do you have internet? What kind of data sources are available, and what are available resources? And if I don't have enough resources to survey all Beirut, and I don't have enough trained data collector. Again, this is a factor that should be thought about when I think about recruitment. So this is an example where in a study, this is very much a methodological type of study. This is a study that looks at, this is by Manger et al., invitation to a population-based cohort study, differences between subjects recruited using different strategies. So what they were looking here is that if we use different strategies, do we get different types of people? Okay, so Anna, if I want older people to be in my cohort, people who are 60 plus, not a representative, but just inviting older people to be in my cohort. So what can I do? What do you think this could be? How can I do this? I can do passive recruitment, meaning that I can just post pamphlet, flyers in public places, here at the University Health Services, and bank, liquor store, sorry, that does not look like in Lebanon, and chemist meaning in pharmacists, libraries, primary healthcare, and hospital. So places where that are visited by older people. So this is one way. It's called passive. Another way of recruitment, and we're trying to see what kind of people I can get for my cohort, is to do more active recruitment. So the population that I'm interested in, I can invite them by letter, and I can go to their places. I can knock on their door. So this is more active recruitment, personal invitation, knocking on the door. So what this study has done is they tried to compare what are the characteristics of those who are recruited using passive type of recruitment compared to active type of recruitment. And there is something called active early, active late. Let's not think about it. So I'm going to think about this part, which is passive versus all active. So would anyone be ready to interpret this OR? So OR it's the odds of participating. Okay, so odds of participating, odds of having that particular exposure among participants who were recruited in passive manner compared to those who were recruited using all other active strategies. So can anyone pick up? So can we look at education? So if we look at education and look at university, so can anyone interpret the 0.89? Please take your time, think about it, and I'd like one of you to interpret and tell me what you understand from it. You have to try, please. These are data. This is an API study that looks at methodology. So this is not looking at what is the effect of smoking on bladder cancer. This is looking at what is the strategy that works best in recruitment for cohort study, or what are the characteristics of the population, of the cohort, when you choose passive versus active. Yes, Abdulrahman. Yalla, give it a try.
The odds of being recruited in this study in university students is through the passive recruitment has 0.89 the odds of that of being recruited through an active.
How is it related to university? Okay, so let me please, but just be careful. You can have another try. So the reference is what? Is less than 9 years of education, right?
Yes.
So we're looking at what's the odds of being passive, what's the odds of being recruited through passive strategy in university compared to less than 9 years. So it is less likely that people in university to be recruited through passive recruitment strategies. Did you get me? So when you are in a university, okay, it's less likely to be passive versus all active. And it is significant. Does that make sense?
Yes, yes.
Okay, or not?
Yes, I got you.
Okay. So here, the younger age group, more likely, so the younger age group, okay. So as people have, I don't know if there is a trend, but let's take the 60 to 65, it's more passive, okay, more likely. So the odds of being 60 to 65, or the odds of passive in 60 to 65 compared to 50 is 1.93, okay? So more likely to have older age group and the passive recruitment, which is something I actually not very much, but what it tells you is that it really differs. It differs between, in terms of recruitment, between the passive and the active recruitment, okay? It produces different type of population. So you capture more, for instance, people who are staying at home, you are capturing more people who go a lot to check up in dispensaries. You are less likely to maybe have a cohort of people who are educated if you use a certain strategy versus the other, okay? So that's the message. Okay, so let's take another one. So this is again recruitment strategies for recruiting a pregnancy cohort. So they tried. These are women in Edmonton and Calgary in Canada, and this is the article is the most effective strategy for recruiting a pregnancy cohort, a tale of two cities. And so if you look at Edmonton versus Calgary, so we start with recruitment in medical offices by physician and staff. So they have collected data on 1,200 from each city, or I think Edmonton is much more than a city. Is I think it's like a small district. So the highest percent in Edmonton, they were recruited from word of mouth and from medical offices. In Calgary, much more. 33% were recruited in from medical offices, or people coming to have ultrasound or something. So what they have ended, just to read the final conclusion, is that the most effective strategy overall involved face-to-face recruitment through clinics and physician and ultrasound offices. So for pregnancy, irrespective whether it was Edmonton or Calgary, the best approach to recruit pregnant women was in a clinic. So women coming to a physician for prenatal care or coming to do an ultrasound. Okay, this method was most economical when clinic staff receive an honorarium to discuss the study with patient and forward contact information to the research team. So it was more efficient, and we had a higher yield than people who have looked at the media. So they were recruited. So we have very few recruited from the media, especially in Calgary, less through TV advertisement or internet, so on and so forth. So the highest was this face-to-face recruitment in clinics. And this is another one. We're looking at, this is the same. So they compare 5 strategy with respect to overall recruitment, success, efficiency, cost, and fulfillment of scientific requirement. Again, they had the way they have collected the data were enhanced recruitment from clinics. So the 81 was the doctor's clinic. So most of them here, the highest yield, these are the yield, and a woman enrollment rate, and this is newborn enrollment rate, meaning that they approach them to enroll them in the study and then later to enroll their kids. So the best one was taking all, the optimal was provider-based, so it's provider-based and with other special provider-based was mostly for the kids, okay, for the newborn enrollment. And the DO, I have to think about the DO, I forgot. But just to note, again, and the most important message from this one is that it really differs. The type of strategy also would dictate what would be the proportion of women who would enroll, which means participation rate. And that one, it specifically talks about the participation rate. Okay, it means your success in enrolling women in your cohort. The earlier one, it talks about more the type of people that you will get based on your recruitment strategy. So here we have passive versus active. Okay, so you will have a different people with different demographic characteristic when you choose one recruitment methods over the other. And the other one is you will have a different yield, meaning that participation rate depends on the type of recruitment or strategy that you use. Okay, so what they said is this is the direct outreach. This is direct outreach, so coming to the women who are pregnant. So with the exception, all strategy enrolled a cohort of women whose demographic were similar to county natality data. So here, irrespective of what strategy they use, the characteristic of women was the same except for the DO. The other one, it was really different, depends on the passive versus active. So the key message is different recruitment strategy might attract different types of people. And the issue is that when these differences occur, they might be not at random. Yani it happened that we have different people. They might be important differences based on the strategy, and these important differences could be related to the exposure and health risk. For instance, if you get more educated, and the more educated have better cognitive reserve, and the better educated have lowered cognitive decline, this will affect both your exposure, which is education, and your cognitive decline. And you will be including more people who are educated and who will ultimately have better outcome. So therefore, it is important to have to think about the non-participation and think about whether your non-participation can introduce any bias, because this could jeopardize your internal validity. Now, if you are recruiting, it's a voluntary recruitment, you expect that you will not have voluntary is always associated with selection bias, because you volunteer in a study because you have a particular interest, maybe because you have the exposure or because you don't have the exposure. You could be very healthy, or on the other side, you could be really having many health problems. But anyway, one has always to compare those who participated to the non-participant and try to see whether they differ in terms of basic characteristic, because otherwise, if they do differ, this might jeopardize the study validity. There was a systematic review on participation bias. I will share with you the article, and it was systematic and meta-regression analysis, and they found out that age, year of baseline contact, and study region were associated usually with participation. These are like across all the cohort that they have looked at. Age is important because older age groups, sometimes it depends on the cohort, of course. And when they are contacted, and sometimes the region, that you might have the differential participation based on the region. So just as example and illustration, the SHARE is called the Survey of Health, Aging and Retirement in Europe. This is a cohort study that is conducted in more than 20 European countries. It recruits a cohort of 50 years and older. The way they recruitment is based on probability sample. It means that they should be representative of the population. of the population distribution. They rely on national sampling frame or population registries. The response rate have been reported to be 62% participation when they establish the cohort, or even at every level. The last C is a longitudinal aging study in India. This is so longitudinal aging study I for India. It recruits 45 years or older with their spouse. It's a multi-stage stratified sample, very much that resemble the Al Sahha, the Lebanon study, but it's broader in scope. It takes 35 states and the union territory across India. So first they identify the household, and from every household they take at least one age eligible, meaning 45 and older, and the spouse. And they got a response of 87.5%. So when you visit the household, they screened for eligibility, and then they did the collection. They got a very high response rate, higher than us, but us was also very good. Canadian longitudinal study, it promoted participation through national awareness campaign, community outreach, physician offices. So one was a telephone cohort, and the other one was in-depth cohort through provincial registration databases. It includes 45 to 85, but yet the response rate was 45. So this is not representative, but through more passive, some passive using media and some doing outreach and direct contact, but yet it was not very successful. Okay, so I will talk about exposure and then stop quickly. So which exposure information? So when we talk about exposure information, there are so many things that we'd like to collect data at baseline. It could be exogenous variable. We're talking about risk factor, right? So environmental, infectious, social and environmental. It could be biological or genetic makeup. So I could be collecting data on hormones, genetic predisposition, family history, but I can be also collecting data on lifestyle risk factors. So it could be environmental exposure. I can think about even maybe war as an exogenous. So war as an exposure, a social environment, war, exposure to crises, economic crises, childhood adversity, people suffering from hunger when they were kids, participant who suffered from the death of parent when they were kids, the major trauma. So all these are social and environmental exogenous factor, endogenous, biological or genetic, or lifestyle factor, which are the modifiable risk factor, in addition to socio-demographic and confounder. So these all make up the exposure information we collect at baseline. But it boils down to what are we interested in? So are we interested only in looking at an exposed at unexposed at baseline? So you collect data from a cohort and you just collect data on whether they are diabetic, yes or no. And then when you follow up, you only look at what was their diagnosis at baseline and what's the effect of their diagnosis of diabetes after 10 years. So this is exposed and exposed. It could be ever exposed. So it could be, have you ever been exposed to a war event? Just ever. Have you ever smoked? Okay, not even. So it's a lifetime. But it could be also very important to specify sometimes the period. So the physical activity. So some of you who attended yesterday's dementia. So dementia, when we talk about the effect of some NCD on cognitive decline, it's not about having a hypertension when you are 70, but having hypertension when at mid-adulthood. So therefore, the exposure should be noted, assessed during a specific period of time. So when I ask about exposure, I should ask, have you ever been diagnosed with hypertension? When were you diagnosed with hypertension? Because ultimately, I'd like to build a variable that is not only people have hypertension, but have hypertension at midlife. Have you had Have you been exposed to death in the family? I want to make sure, I want to assess childhood adversity. So therefore I ask, have you experienced death of one of your parents when you were 12 years and younger? And of course, there are multiple exposure assessments, so not only one, more than once. I mean, multiple, yeah. When you ask about if they were exposed to war, how many times, every time for how long, when this happened. So we're not talking about ever been exposed to war event, but how many event, how many times you were displaced, how many times your house were bombarded, how many times, how many members of your family has been injured, intensity of exposure. So we're talking about smoking dose, not only how many, not only whether they smoke, but also for how long and how much. Source of exposure is important as well. Where did you get your exposure on I don't know, radiation or whatever? Have you only taken like X-rays, or have you worked in a radiation and radiology department? And change in exposure, meaning that sometimes my exposure is not static. I might want to look at not only at the baseline, but if people change their behavior, maybe they have reduced their smoking, BMI at baseline by that, but then whether they change, whether the BMI change. So it's not only smoking versus non-smoking. It's not smoking versus non-smoking at baseline, but how people change from smoking to non-smoking, how people move from higher BMI to lower BMI. So what are we interested in? This should be in your hypothesis. When you establish the cohort, what is it that you want? You just want, do people exposed to war have lower cognitive? Do you want to look at if women smoke in pregnancy, whether she would have complication? Or you want to look at smoking during the first trimester of pregnancy. You want to look at heavy smoking among pregnant women compared to no smoking. You want to look at the type of smoke, whether you want to look at overall exposure of smoking from primary and secondary type of sources. So all this should be thought about, because this is how you will assess your exposure and then convert your concept or your measure that you are interested in an indicator and specific measure that you want to collect data on. And then when you think about exposure, you always have to think about what assessment method I'm going to use, what's the best valid one, what others have used. You need to harmonize your method of assessment with others. You have to keep in mind whether any type of measurement is changing over time. Sometimes when you classify people into diabetic, non-diabetic, maybe the cutoff have changed from this year to maybe in a few years. Sometimes, so the instrument even that you use, you have to make sure that you're using the same instrument. And if instrument changes, you have to keep track of it. Are you going to do several measures of exposure? So are you going to do every 2 years, call the people and say, how are you doing? Are you still smoking? Have you been, what's your weight and height? And then have multiple measures of exposure. So therefore, this is something that you a priori think about, because you need to look at the changes in the exposure, not only whether the exposure is at baseline. And of course, you have always to think about the reference period. When you go back and you ask when this happened, for how long it happens, you always have to think about the reference period. So as you're doing this, always keep in mind cost consideration. So when we write a proposal and we present, usually a cohort, we present a proposal for 5 years of funding. So we have to keep in mind that let's say if we did the second year, the wave 1, that we have a wave 2, and then we need that amount of money to trace the people and to collect the data on exposure. Do we need to take blood tests? Do we need to do a clinical exam? Are we going to have some blood biomarker analysis? So all this needs to be and this is for the outcome, but no, Even this could be for the exposure. Do I want to see their level of HbA1c, diabetes? So all this should be factored in. So the measure assessed are through different ways. It could be interviewed. So like any study, it could be a physical examination, like we're doing now. We're looking at grip strength, timed walk, lung function, balance, height and weight. We can be taking saliva, blood sample, urine, medical tests. Of course, the more objective, the better. The more objective, the more costly. And think also about administrative data. And important is also to think about whether data exists in medical record or any other exposure record, such as food diaries and record in factories. And think about if you have any types of measures of the environment that you are interested in to get something about pollution or stressful event or something. Let's say you can monitor the hostility of the Israeli using from daily news, from social media. You don't have to collect data from people, for instance. This is one way of collecting data on hostilities. Okay, and then keep in mind is, do I want repeated measure? Why do I want repeated measure? If you want cumulative, do you want to see fluctuation? Do you want to look at how things vary by time? So if people age, if they change their exposure, and you have to think about the time frame for collecting the repeated measure. So is it every year? It becomes very costly. It becomes very difficult to analyze. And what if I do a repeated measure and I get a lot of missing data? So you have to think, what would I do? So I need 3 measures and I have only 2 measures of a person. So therefore, a priori, you have to think about how much missing data you might end up with, how to handle them. This is more statistical, the statistical part of follow-up studies. If you follow up and then you lose some people, or you don't get wave 2 data on person who was missing, who was not responsive, what would you do with this data? And always keep in mind cost. So what people do, what researchers do is, so you have wave 1, wave 2, wave 3. This is cohort. So wave 2 or wave 3, instead of collecting data on all the cohort, they collect data on a subsample of the cohort. So let's say in wave 2, I collect again data on all the cardiovascular risk factor. In wave 3, I don't collect anymore on cardiovascular risk factor. I repeat the data collection on, for instance, lifestyle factor, so on and so forth. So having a sample of cohort rather than, again, revisiting and re-interviewing the full cohort. Okay. I'm sorry, I had to finish as much as possible. Cohort is a lot. It's a lot of information to consider, because just assembling the cohort and the strategies are really very different for every different cohort. Exposure as well is very important. The case control, we spend a lot of time thinking who is my case and what is the best control group. And in cohort, it's the issue of what will my cohort look like, and how do I assemble a cohort, ensuring a good participation rate and ensuring a cohort that represent actually my planned cohort with particular characteristic. Okay, so that's it. Any questions? So we have Thursday. So Thursday, we still have the outcome, some consideration for the outcome, and then we have the analysis of the cohort data and discussion of an article. 1 or 2 depends on the time that will allow us to work on this. Okay. So I'm sorry I did not keep track
thank you,
of the
Doctor.
chat. Let's see if I have anything in the chat. I don't think there's anything in the chat. So any question? Was it clear? I think it's a lot of information. I hope that you will have a chance to revisit, to read before next time. And you have some readings and on Moodle, some resources that you can read on Cohort. So I hope that you would have at least reviewed the handout, to have read an article at least, or at least one illustrative article on maybe retrospective and prospective cohort, and we'll continue on Thursday. All good?
Thank you, doctor. Yes,
Yes,
thank you,
thank you,
doctor.
doctor.
Yes, all
Thank
good.
you. Thank you. Please take care and stay safe. And hope to see you in person soon. Ciao.
Bye, doctor.
Okay, I will share the recording on Moodle as well.